Hey, good morning or good afternoon, depending on where you're located right now. We're going to give people another minute to join. And just FYI, we will be recording this webinar. Jeff, if you can hit record, that would be great.
It looks like it is recording.
Oh, great. Super. Awesome. All right, we're going to get started. We got a great group today. Thank you for taking time again for coming here to our event. Our webinar focused on physician organizations in Michigan, why they matter to the ecosystem, including HIT vendors. Today's panelists are going to be Angela Vonker, Executive Director of GMP Network, Dara Barara, Director of Michigan State Medical Society, and James Morris, CEO of Health Focus. Joining me as well today is Jeff Babe, who is the president-elect of the Michigan HIMSS chapter, and I'm Art Nicholas, currently secretary of the Michigan HIMSS chapter. With that, I'm going to get started with Dara and give us a little background of yourself, your profession, and how you got involved with the Michigan HIMSS chapter.
Um, so I am Dara Barrera. I am the Director for Health Quality, Equity, and Technology at the Michigan State Medical Society. And I have been with MSMS for almost 18 years. So I think the standing joke is we started when we were 12, child labor. But so I have been actually part of the Michigan HIMSS chapter since the kind of the end of 2014. And you'll hear maybe a similar theme between a few of us. I was actually told I was on the board before I even knew I was on the board. I was helping out with our large multi-state technology conference with the chapter, and one of our past presidents decided that, Dara can be on the board. And so since then, I have had a number of roles, including president. So, there's a few of us past presidents on as well. And, working with this group has been great professionally and also for all of our physicians who are members of the Michigan State Medical Society. So there I work with physician practices, physician organizations, health systems, payers, the state and federal government. So, we are, very much on the policy side of, delivering healthcare in Michigan and work with a number of groups. So,
Awesome. That's great. Thanks for joining us today. Angela, you're up next.
Hi, everyone. Good afternoon. I'm Angela Vanker. I'm the Executive Director for GMP Network. GMP Network is a physician organization, independent physician organization located in Macomb County, and we serve physicians throughout the Southeast Michigan area. And obviously, why you're here is to learn a little bit more about what that means. So we'll get to that shortly, but just a little bit more about me. I started my career at MPRO, which is the Quality Improvement Organization for the state of Michigan. Worked there on also the Regional Extension Center for the state of Michigan, and also had in a previous life worked at a multi-specialty practice, putting in care teams. So I've worked with physician offices for the past 20 years. So I have a lot of passion that I bring to that topic. And then just for my Michigan HIMSS story, while I was doing all of that, my story is very similar to Dara's in that I was brought in to work on the Midwest Fall Technology Conference that we had in Michigan that brought various states in the Midwest together for different programming. And from there, I have not left HIMSS since then, Michigan HIMSS, because it's been such a great group of people to work with, and have also held a lot of the roles on our board. And I'm really thrilled to the Michigan HIMSS asked me to present on this because it's something that'll be a great passionate topic that to talk about. So thank you all and look forward to talking more.
Great. James?
Thank you. So my name is James Morris. I am the CEO of Health Focus. I guess my background, I have no business working in healthcare. I'm a political scientist by background, but I ended up in the healthcare ecosystem about 15 years ago, and it's impossible to claw your way out. So I've been here ever since. I've spent some time at the Bureau of Medicine and Surgery, supporting some of their clinical initiatives. Worked on the Eastern Seaboard on the urgent care side. I had a tenure on the physician organization side in Ann Arbor. and then spun off into an independent population health software company back in 2020. So we work with a large number of groups in Michigan, but we also operate in between a lot of organizations. So we have sort of a unique perspective on the role that the POs play in the broader ecosystem. Very excited to be part of this conversation, and thank you all for joining us.
Great. And before I get started with questions for the panel, I neglected to say we are going to accept questions from the audience. If you could do that in the Q&A box, and Jeff and I will be moderating that and get to your questions after we hear from the panelists. So just setting the stage, to help our audience understand the landscape. And Dara, we'll start with you. Can you each briefly describe what a physician organization looks like in Michigan, and what makes that this ecosystem a bit unique compared to other states?
Yeah, I know Angela can get into more specifics, but in Michigan we are very unique. And so when I work with other medical societies from across the country and with national organizations, I always have to explain that Michigan doesn't just have a couple very large health systems then that everyone else works around. Roughly 20, 25 years ago, because of Blue Cross Blue Shield having such a large foothold in Michigan, they started a few initiatives, and that actually started how independent physician practices and employed practices, but in a different way, started grouping together. And that was to bring them together to do quality initiatives, to do contracting. Different types of partnerships have spun out of that, now moving into risks and ACOs and a lot of different things. But when it very first started, it really was around the physician group incentive program, how quality metrics were rolled out, how they were able to report these, and moving into things like patient-centered medical home. And the physician organization really turned into this umbrella that independent practices fell under to do all of this work so that they didn't have to try and do it all on their own. Since then, it has grown into very large groups that do a lot of different types of business for their practices. And it's become its own ecosystem with how these practices communicate up through the physician organization and then to payers, to health systems, to labs, and other things across the state, kind of like with Health Focus. So it really started off as a way to track quality metrics, and now it has turned into an entire healthcare delivery system of its own.
That's terrific. Angela, given you're executive director of one of these physician organizations, you want to add to that?
Sure. Yeah, Dara did a great job with that high level, and I think I'll just to add to it is that there are 33 physician organizations currently in Michigan that represent over 26,000 physicians statewide. Both primary care and specialty are included in those. And you'll hear us say POs for short, because physician organizations can really wear on you after a while, but POs really serve as that liaison between physicians and the payer, like Dara was saying. So it's really to assist the physicians in achieving their various goals. So they have physician level incentives. There's also PO level incentives that really the Michigan payer landscape has embraced as a way for physicians to earn dollars and also to improve their care. That's a big part of it. So there's a lot of resources that POs provide, such as quality support for the quality measure thresholds, technology like the population health support that Jim represents, and then there's people support. So there's a lot of work around care management. We have POs that have brought on CHWs, community health workers, social workers, all different care management staff, behavioral health, all in the vein to be successful in value-based care. The other thing I just want to talk about too is that there's different types of POs. Again, Dara alluded to this. There's physician hospital organizations that are associated with health systems. There's now clinically integrated networks that are made up of multiple POs. And then there's POs with employed physicians from health systems and independent physicians. And then there's independent POs that represent all the truly independent physicians. So you can see how it's evolved since it started. And all of us have different levels of support that we provide based on our technology. So there's lots of different versions of a PO that you may run into.
That's really helpful. Jim, what would you care to add?
So it's hard to follow up on defining POs after Dara and Angela here, but I would mirror Angela's statement here that the term PO, really looking at it from a national standpoint or looking at it from the broader market, is sort of an umbrella term, and it encompasses all sorts of abbreviations. We have ACO and CIN and IPA and PHO. And I would recommend that we add a new one as an MPO for a Michigan physician organization, because all of our experiences, everybody that we've talked to does differentiate. And they do say that there are differences in how Michigan is structured. I think what sets Michigan apart is really the level of governance, the strategic initiatives, the coordination across the practices, and the direct engagement with those organizations that we don't see on that national level. I would say the uniqueness in Michigan is the scale at which these POs are expected to operationalize data. And it really changes the way that we look at it from a health IT standpoint and how to support these types of organizations as well.
Great. Appreciate that. Jim, we're going to stay with you for this next one to start. Building off of what the three of you have shared, can you go into maybe a little bit more detail in terms of how the POs play in coordinating care? But take it from the vantage point of, if I'm an HIT vendor, why should I be paying attention to the physician organization as it relates to care in Michigan?
Yeah, I think Dara sort of started this line, but POs really sit at the intersection between the payers and the providers, and they are fundamentally the implementation engine. So they're where the workflows begin, and they are where we normalize and standardize data to make it consumable in multiple directions. So you think of data flows operating on a vertical line here. How do you communicate information from payers down to the practice level, and how do you take practice level data and consume it at the payer side? And the POs are really the ones who are accountable and manage that transfer of data and really valuable intelligence. And working with them is what makes it sustainable. I think that ignoring POs from a health IT standpoint, you really miss the decision makers. You miss the organizations that are managing the funding, that are really in charge of adopting technology and clinical workflows on behalf of their practices, and are really the source of authenticity. I think that because the POs are representing the interests of the providers, they are the ones who are able to take upstream data and present it in a way that is consumable and that the providers are willing to engage with. I think some of the difficulties that the POs really have to navigate here is where they stand within those intersections. So they have vastly different capabilities and technological solutions at different EMR and practice levels. So different EMRs, different performance capabilities, different workflows that are designed everywhere, and different levels of technical maturity. So when we talk about rolling out solutions at a state level, it can't be done at the payer side. The payer can't roll out a unilateral choice for the providers and how they operate. Really, that needs to work its way down into the organization that can turn those requests, those contractual requirements, into something that can be part of both workflows and operational workflows for the practices. They matter because they convert value-based care contracts into an operating system in which we can all navigate.
Thank you for that. Angela, what are your thoughts on this topic?
Well, I'm totally going to steal Jim's implementation engine phrase that he used for a PO, because I think that's a great reflection of it. And just to kind of add on to that, so I'm going to speak because I'm an independent PO that represents independent physician practices. So really what matters to us in terms of what for coordinating care and what helps us is that there's a great amount of flexibility that we have to achieve certain goals. So, and that's often driven by the physician and their practice that we represent. So if a practice is struggling to complete, and I'm just going to use an example for coordination of care. If a practice is struggling to complete retinal eye exams, a PO can work with the practice to schedule those patients, provide the staff and equipment to complete them. We have all that flexibility to bring that to them. If they're struggling with billing or coding documentation, we provide the reports and the resources to help them get that done and help to educate them one-on-one to be able to do that. So in my mind, POs have more autonomy with decision making. There's nothing that has to go through committee for approval. There's nothing that have to go up the food chain to get things approved. So to me, the needs of the physicians are met more quickly and efficiently, and we have a history because of how long we've all been in place to meet those needs for them.
Dara, how would you like to round out this conversation?
I will actually round this out by just reminding everyone that, especially in groups like Angela's, where they are an independent, these are all independently owned businesses. These are, for lack of a better term, some are large, some are small, but mom and pop owned shops. These are independent practices who are running a business and employing people. And so not only are there decisions that they can make on their own at that level based on what type of technology they want, what type of EHR they want, what type of computer they want. But then they also need to meet, these other measures that Angela's, like at the PO level is helping. So when you're working through a physician organization, they can actually assist with, translating what you may be trying to work with a practice on because they may not have somebody in that practice that is extremely technology savvy or may understand what you're discussing with them or know why they need it. Or they are just another level of trust to go to for an opinion or for assistance. So you have such varying levels. It might be a practice that has 25 people on staff and someone dedicated to working on health information technology, cybersecurity. It might be a small practice with one physician and three staff who have absolutely none of that experience. So the PO really is also that level to give information to practices that can assist you when you are working with them.
Having worked with organizations throughout the United States, I can tell you, Michigan practices are really fortunate to have this structure in place because a lot of people struggle exactly with the things that you said, Dara, right there. So before we get into the meat of some of the specific challenges that are going on relative to information exchange and technology, I wanted to just, try and drill in a little bit more about for the vendors in health information technology today, what makes a physician organization easier to work with from their perspective? And then the flip side of that is, which is probably more important for this audience is what should a health information technology vendor do to be a good partner with a physician organization? Angela, I'm going to start with you on that one first.
Sure. So for us, it's really an understanding of what the full picture of what the PO has with their physicians and listening to them on the many issues that come up in a day-to-day physician practice. Just like Dara said, they are a small business. There's a lot of other things that are on their plate. We're the trusted voice that comes to them to recommend or to talk through what they actually need. So among all those 33 POs I mentioned, not one of us has the same makeup of practices, the same structure, the same workflow, because we all tailor to what each of our physicians need. So the support in the UP is going to be much different than the support needed in Southeast Michigan, just based off resources. So we all have the same targets and goals because we all have similar things that we're working on with the payers, but we all have to go about it a bit differently. So we're all POs though are willing to partner so long as there's that two-way street.
Okay, how about what do you look for in an HIT vendor to be PO friendly from your vantage point?
To me, it's not just giving us the cookie cutter version of what the product is. Work with us to figure out how can we make it usable for our physicians. It's tapping into one of my answers for another question, but
Yeah.
it's really to make it more flexible for them and not just be able to say you got to use it out of the box.
Understood. Yeah. Dara, what are your thoughts on this question?
I would echo everything Angela said and know that in our state, you have concentrations of health systems in different areas, and those health systems are expanding. And with that brings challenges to both types of practice, so employed and not employed, because depending on where you sit in the state, there's always work around high-speed internet. There's always work on connectivity. There's always work on, reach to patient. But so when you're looking at it from a vendor perspective, how people work in one part of the state is very different than how they work in another part of the state. And I'm not even just speaking, cookie cutter technology. I'm talking, lingo is different. We have some very different parts of Michigan. So I would look at Michigan as you drive through the ecosystem, the thoughts, the access, everything changes as you move not only east to west through the state, but north and south. So knowing that, one area is going to be very different than the other area is also extremely important for vendors to consider. Even with what you wear when you meet with people is different depending on
Yeah.
what part of the state you're in. So, suit and tie versus, hoodie. You could be anywhere in between.
We definitely have a very diverse state.
We
I think,
do.
people, outsiders may think of Michigan and they think of the Detroit, metropolitan area, but there's certainly a pretty broad expanse, including a number of rural healthcare communities as well. Jim, you want to weigh in from a
Yeah,
vendor perspective?
I'll start with sort of what we look for in a really good PO partner. And I think the first piece is we want to see an organization that has a really simple, straightforward, compelling mission and solid strategic initiatives. And what I mean by that is we need to understand how they're measuring success. Population health is so expansive, and there are so many things that you can focus on that we need to understand what is the organization's unique set of priorities. And as it's been stated by both Angela and Dara here, each PO is very different, and the needs and the difficulties, the things that they're trying to overcome on an annual basis vary regionally and based upon their provider makeup. So having an understanding of what their driving factors are helps us make sure that we can align. The next piece is the ability to operationalize data. I would make a bold claim that for many POs, when you look at discrete assets, the most valuable thing that they have is data. And the inability to turn that data into workflows or operations, and really through the help of HIT, that's what we're there to help assist with from that workflow. But understanding that that's the goal, is to turn the assets that they have into something that they can operationalize at the practice level. The final thing that we look for are groups that really see data as an opportunity instead of an adversarial process. If an organization is fighting against their own data the entire time, instead of taking a look prospectively to say, what can we do with this, right? Even if there are problems, even if there are interoperability difficulties or normalization problems, what can we do with what we have to make sure that we're aligning to those mission and vision statements that we have, aligning to the strategic initiatives to make a difference on that annual basis? Those mindsets and really structural or governance models we found to be some of the best indicators for a successful relationship for marrying HIT with the POs. And I'll actually weigh in on the health IT side too. And I'm going to borrow a statement from my wife. So she requests often that I listen to understand and comprehend, not to respond. And I think that's really important from an HIT standpoint to say, what exactly are we trying to achieve together? And to Angela's point, out of the box isn't going to work for Pop Health because the market is unique, because each PO is unique. And furthermore, every practice is unique. So how do you work as an HIT vendor to amplify the existing workflows, to figure out what the POs do very well and make them even better, and identify those opportunities for ways that we can refine instead of creating new workflows for everybody to undertake. So I think it's about that relationship and really looking at that relationship as defining a way that we operate together instead of just an out-of-the-box reporting exercise to give you something that you have to reconcile against all of the hundreds of other data points that you're receiving.
Jim, thanks for sharing your experience there. That's great advice. This next question is something that you've each touched on a little bit so far. And it's interesting timing-wise because I was at a Meditech user group, not in Michigan, and we were talking about TEFCA yesterday and the magical, wonderful solution that TEFCA is going to be in terms of data exchange. But the reality is, Michigan has IHIN as the state designated HIE, and we've got various physician organizations working across the ecosystem. Has TEFCA just waved the magic wand and we have no more issues in terms of data exchange between organizations, payers, and health systems, or do we continue to have challenges? And if we do have challenges, which I think I know the answer to that, how can HIT vendors fit into solving those questions? So, Dara, I'm going to have you go first this time.
To be the person who would hold that magic wand, that would be amazing. I have spoken for years, and this was even back when we were, we had, as a state, decided on the structure of MIHIN, so our Michigan Health Information Network. And at that time we were hub and spoke model, how things were going to move forward. And, within about 2 years, we were going to have this HIT data exchange utopia. It was just going to be there. And as a patient, I would go to the UP and something would happen and all my information would just be there and I wouldn't have to bring anything with me. We've been talking about that for a very long time. And obviously, as the years have gone on and as technology has evolved, instead of, in a lot of ways, getting rid of these barriers and roadblocks, we have created more and more and more. Because with more data comes more roadblocks. I do not think that there is going to be a press the button and all of these issues are going to go away. There are too many legacy systems out there that work well and that health systems, practices, the entire healthcare ecosystem is not going to just get rid of because of one thing. It will take time for vendors to get up to speed when these changes happen. There are state and national policies that have to change in order for a lot of that to happen, let alone, individual organization-based policies and metrics that will have to change. Payers will have to get on board. There's just too many moving pieces for one thing to fix it all. So are we all hopeful that it might smooth a few paths? Yes, get rid of a few potholes. Hopefully, it's not going to be, smooth sailing and easygoing. People will still need to figure out ways around and fix things. So I don't think it's one size fits all, if that.
Yeah, thank you. That's a very direct and honest, experienced answer. And Angela, what are your thoughts and where do you see a vendor being able to help reduce, if not eliminate, this problem?
So I'm going to actually get specific because there's things I hear about from my team all the time about the current, accuracy of data and the full picture of data. So I'm going to focus on a couple areas. Just bear with me here. So the first being, I hear all the time about patient matching. It's been, continues to be source of concern for data exchange. The amount of information collected, the number of changes that occur year to year, even month to month, the missing and inconsistent data. So it's a bigger problem that doesn't seem to get discussed as much as it probably should. And really, it doesn't help us figure out an accurate patient population for our organization or our physicians because of all these contracts we have coming down the pike, especially the risk-based contracts. That's really important. So I kind of looked at this as more foundational in terms of what our concerns are from a PO level, because that sort of thing, while it's not the flashy, sexy thing that everybody talks about, it's an extremely important aspect of our data that we need to make sure is complete and accurate in order for things to be built upon. So the question, I don't expect HIT vendors to solve all of these issues or to have that magic wand. I think, though, there needs to be an acknowledgement that there is this data integrity issues that we still have amongst various systems, and that we need to continue to look at fixing the foundational core of our healthcare ecosystem, because I think we sometimes tend to go to the AI and we think that there's all these tools and tricks that we need to have in place, but there's some really foundational things that need to be looked at too.
We made it 30 minutes before the term AI came into the conversation, and we'll get back to that in a minute or two. Jim, anything you want to add?
Yeah, I think I'm going to back up and speak a little philosophically here for a second, but I think there's a difference between the concepts of connectivity and usability. And I think that's something that we as a health system, as a state, need to address. And I think as we look at connectivity and how we work with MyHIN and HIEs, I think generally it's a multi-phased approach. And the first phase is to try to incentivize, to build a connection, foster engagement. I think as kids, we all grew up learning how to share, and then we learned that that was dangerous, right? It put us at a disadvantage in the market. So how do we retrain that? How do we make sure that we're developing and fostering an environment in which organizations want to share data? But even then, once we start to build these connections, how do we turn that data into true clinical signals, right? How do we make sense of it? How do we make sure that we understand what's coming through on the other side? And how do we prevent connectivity without purpose, right? How do we prevent collecting data without a delivery endpoint, without understanding who the target audience is, what the workflows are? And more than saying how HIT can fix it, I'm going to kind of raise the flag to say, I think one of the problems is that HIT drives the process and drives the connectivity without understanding what the workflow is and what data actually needs to get where in order to affect it. So I think there needs to be a clear understanding of why we're seeking this connectivity, what's the value proposition, and it needs to be able to translate down to that patient level. Whose data is it? Why is it getting sent, and what impact is it going to have for them? And then I know we're halfway through, so I'll try to be brief here, but I am going to get specific too, like Angela here. One thing that I see as a really difficult thing that I think we need to start talking about, we're moving from a measure standpoint, clinical measures, toward a lot more episodic or event-based measures. And historically, we've had this call and response relationship with the payers where they push out treatment opportunities and gap lists, and the POs can respond, build workflows, and send that data back. But where we're really ending up now is the POs need to be on the sort of the front edge of this, anticipating before services are identified, before opportunities are presented, so that we can develop workflows that are more dynamic in that communication line back to the payers to say, hey, this patient showed up in the ED, they were discharged. We're going to go ahead and hit this hard from transitional care management, doing our med recs, preventing readmissions. None of that data is provided by the payer yet. So how do we make sure that the historical data pipelines that we had to support more annual-based measures are updated to reflect that reality shift here?
Terrific. Well, because we actually promised people we're gonna hold this to 45 minutes so that they can grab a little bit of lunch, I'm going to move forward to a topic because I do want to leave time because I've seen some questions already pop up. Okay, as I mentioned earlier, we made it 30 minutes without the term AI coming into the conversation, but we would be remiss as a organization if we didn't talk about that. So, Angela, I'm going to start with you. So, gee, what a surprise! AI in healthcare is getting a lot of attention. From your perspective, what do you see as the most promising thing of AI helping your members, and what's the most overhyped?
So this is an interesting one because I had to really, really think about this because there's so much coming out all the time about it. And so for me, what I've seen that's been most helpful in real practice is really the AI support for documentation for physicians. Whether it's the AI scribe or the clinical documentation support, the CDI support, that's, I think, very useful because it just helps with efficiency. It's not putting in clinical decision making, it's just helping them be more efficient in their practice. So when it's used appropriately, when it's accurate data, it works really, really well. What concerns me most about out there, and I wouldn't say there's one thing out there that scares me about the AI boom, and I shouldn't say scares. I think it's just more reluctant on certain things, is that because it builds on the information or the data that it has, and with what I talked about with the amount of missing or incomplete data we have on patients, in data exchange and everything else, we could go down some dangerous paths, where AI decision making doesn't have the full picture to make the right decision or suggestion. So that's probably more so that concept is what worries me the most.
The need to have guardrails, right?
Right.
Yeah. So Dara, I know you have to have an opinion on this.
Well, yes. So something Angela just said is very important. So as we know, AI builds off of itself and it may have incomplete or I would say biased data. And so depending on where some of those data points come from, it can depict, a picture of a patient that is completely different than it may for another patient, depending on just even where that data is coming from. And so when we talk about guardrails and policies, everything is kind of on edge right now as far as are we going to be able to make state level decisions based on use of AI in healthcare and in other industry? Um, there's a number of pieces of legislation that are in discussion but kind of on hold, and they are always around one certain thing, and it is and where in that decision making does a human have to be part of a process? So you hear it on the sides of payers, if they're making claims denials, can that be done by AI? Does a human have to be part of a process? If you're looking at decisions around care plans, can all of that be done by AI and not have human intervention, especially when it's making decisions for a patient's health and decisions for payment for a patient's health care? So there's a lot of solid walls that need to go around some of that so that we don't go down a path where healthcare is being put in a space that we can't get back to making correct decisions, regardless of how anything is legislated or what policy is created. So I think, as we are still in that area of not knowing exactly how much a state is going to be able to do, or if whatever the federal government decides to put in place will trump whatever a state decides to do, I think we all need to be very cognizant of what we're implementing, how it's being implemented, and what policies we have written around it. Because there's, now, I don't even want to say a lot of wiggle room. There's no holds barred right now. Like it's
Yeah.
pretty much we can do what we want. So,
Yeah.
yeah.
Jim, do you have a different perspective, or how would you like to add to this conversation?
I would reinforce both points. I think accountability is incredibly important within healthcare. It has to do with how do we trust the data through the pipelines that we're seeing it be processed, and also reiterate a concern around without a full picture, AI will always give you a response, right? Whether or not it has enough information, that's what we're seeing. I would tie it to I have a 7-year-old. She will always give me an answer, whether or not she is at all informed on the situation, right? And can I trust that? Do I take that at face value? No, because I recognize it's a 7-year-old instead of AI who's feeding me that information. So I think there's this sense of blindness to a technology giving an output that we need to be very careful with. I would also just add just a little bit of a funny story here. So we work with an organization who used AI to help fill in some laboratory feeds into their EMR. And we were trying to track down HPV tests and some cervical cancer screenings. And what we found is there were no matching laboratory codes for that, but there was a suspicious correlation to walnut allergy testing. And so it turns out this AI had found similarities in how these two lab results were coded or described, and decided that all cervical cancer screenings were now just walnut allergy tests. So we do need to be very cautious about how it's implemented. I think internally within our organization, we do look at it. It is not part of our solution that we roll out, but we use it as a part of our toolkit for our developers to try to get very discrete information and to summarize information for us. But so far, I am skeptical of magic. AI is not magic. It's a tool.
Jim, you've given us two great ideas for future videos from Michigan HIMSS. A, how to reteach us to share data by watching how children share, and the dangers of hearing what you want to hear or hearing anything from a child, whether they have full knowledge of what they're saying and what they mean. That's great stuff. We'll have to take those ideas. So at this point in time, because we've got a little bit of time left, Scott, you asked a question. Can the group share the best way of approaching a physician organization as an advisor or a vendor? And the second piece of his question was, what role within the POs should be contacted to engage exploratory? So, like, who at a PO would typically be the right person for a vendor to start a conversation, and what's the best approach that they should take? And Angela, since you're executive director of one, I'm going to let you start this.
Sure. So I'll start with the second one first. The role to approach, particularly for, especially with HIT pieces as well, is executive director, of course, but sometimes we don't always know the HIT things that are going to help us. So I would almost even say um, our IT directors, our business operations directors, because they're the ones who often are dealing with the IT within our own organization as well as the practices and knowing what those issues are. So those, to me, those are the roles that would be impacted, because normally if you come to me, I'm going to go right to my IT person to talk through that a bit more. Um, and as far as how to get the information to us, that's a good question, because we get a lot of reach outs to us, especially at least in my role. I know I do. I'm probably inundated quite a bit, and it's really, especially through email, especially of different vendors reaching out for various things, and some things I don't know what they are even are.
Yep.
So I think there's probably I don't know if I have the perfect solution for it. But I think probably developing a relationship beyond just sending an email is probably a better way of kind of having your product be seen and understood. And and I know that's not always easy either, to having that relationship, but I think there's something that's got to set it apart, and an email isn't the way
Yeah.
to do it. Let's put it that way.
So building a relationship through the Michigan Hymns chapter, for
Yes,
example,
there we
might be
go.
one way to do
Perfect,
it.
Art. Nice.
Yeah,
Thank you.
yeah, yeah. So Jim, what advice, given you've done this, right, as a vendor, how would you?
All the time.
Yeah,
Yep. No, I think my advice is really in health IT and in healthcare, there are very few products that I'd consider end cap products, right? You're walking up to the cash register and you decide, you know what, today I'm just going to grab an extra Pop Health registry on my way out. We're going to invest and change workflows and invest in data integration just because that's the topic of the month. So our approach has really been, just to be transparent, to try to attend and participate in group discussions that are very tailored to the problems that we're trying to solve. I think in the Michigan market, uh, the POs specifically are well aware of the resources, the solutions that they need in order to be successful. So I don't think that you need to do a lot to garner awareness of what the problem is. I think you need to develop that relationship, look at what the current solutions are, and communicate and become part of the broader community. So it just kind of to reiterate what Art said and the team, I think participating in groups like HIMSS, going to those conferences that are really centered around the types of solutions that you're looking at tend to be the most helpful for us. And in terms of who to communicate with from the Pop Health side, certainly the executive directors and operations, we tend to lean very heavily onto their clinical team. So if they have practice coaches, if there are managers that are working on care management, anybody who's really engaged in that clinical quality side, who understands and has a good sense of what those expectations are from the payers and the market around them.
wonderful. Dara, as someone that's tutored me on POs, anything that you would like to add that the audience could benefit from?
Bring snacks. No, I'm kidding. So what both Jim and Angela have said is 100%. And we work in the same way at the Michigan State Medical Society. So we have, a number of vendors that, while we may not use the services, we partner with them as sources that have kind of been vetted per se. But I do notice that, across the country, as I've talked to other HIMSS chapters, none of them have engaged, a lot of them are engaged with their hospital association in that state, but not with their medical society in that state. And so that same feeling will then move on to the physician organizations in our state because there are levels that are representing those under them. And so the building of a relationship, the reason of why, your product may be able to help in a way, isn't a one day sales process like Jim said. It's a longer term, it's a relationship build, it's seeing the long game, but it is also, really being in touch with what's happening in the state. And like with Michigan HIMSS, how can you become involved in, it might not only be our chapter, but where are you involved in the state, where you are meeting people and actually having those discussions. It's not just that sales call, how do I get past the gatekeeper in the office? Everybody's pretty much beyond that now and are pretty busy. So you need to be coming to the table with, how can I help, even if it's a resource or a connection that might not be your own. Not providing out of the box solutions, but also, becoming a resource yourself for that person.
That's awesome. Well, along those lines of what we're looking to close out, as we have appreciated everybody staying with us, I did want to share some of the events that we have, if you all can see that on the screen. Wanted to tell you that in January, we had a great event with the health informatics graduate students at U of M. It was a fantastic dinner. Upcoming on March 11th, for those of you that are attending HIMSS in Las Vegas, we will have a networking event from 4 to 6 p.m. at the, Jeff, correct me if I'm wrong, the Accenture booth. And there's more information on our website to register for that and locations. June 17th, it'll now be our 4th annual beer and networking in Grand Rapids at Founders Brewery. We're also looking at a golf outing in June or July, details to be coming down the pike. And then our annual fall conference, September 14th and 15th in the Lansing Center, somewhat the center of the state, make it easy for everybody to go to. Much more information coming out on that and other events that will get scheduled throughout the year. Thanks again. Again, we will share a link to the recording for those of you that registered. And for those of you that are coming to Las Vegas, we definitely look forward to seeing you there. Take care, everybody.